Good morning, everyone. This is Frank Shatpour, and we are presenting a webinar from SDG&E. As you can see, the topic of our webinar is Back to Normal, How to Revert to Pre-COVID-19 Hospital Conditions with OSHPD. I would like to welcome every one of you, and we are honored to have you here. We are also honored to have a panel of very distinguished individuals, and I am going to ask each one of them to briefly introduce themselves and give you a quick background of themselves, and then we will start the webinar.
Good morning. This is John Schrank. I'm the Regional Compliance Officer for the South Region with OSHPD. My background is 45 years in construction, primarily mechanical.
Good morning, this is Joel Sanders, OSHPD Compliance Officer. My background is about 30 years in construction, special inspection, and concrete. But I've been a OSHPD Compliance Officer now for almost 11 years.
Hi, Tim Jacoby. I'm retired from the Navy in 2001 here in San Diego. Spent 10 years at Rady Children's Hospital, and then spent time at Lubbock at Covenant Health and University of Tennessee Medical Center, and then Children's Los Angeles, and then Children's Omaha, and have returned to California to take the Vice President's job at Scripps, and I'm thrilled to be back in California and part of this presentation. Thank you.
And I am Frank Shatpour. I am principal at SC Engineers. We are a consulting mechanical engineers. I also serve as program chair of ASHRAE TC 1.4, which a lot of this information today comes from. And I also teach at UCSD, and I would like to welcome all of my students who are on this webinar this morning. In addition to us, in this presentation, I have here with me Stephanie Johnson with SC Engineers, Jenna Riley, and Justin Dolly with SC Engineers for assisting us. And we also have a registered nurse here in the room with us in case there is any questions. With that, well, let's go and talk about the agenda for today. The agenda today is we're going to quickly talk about the latest research and development, basically ASHRAE. We're going to talk about what the ASHRAE position is on COVID-19, and we're going to suggest a few ideas and solutions. And after that, we have a question and answer period. But I do not want you to wait to ask your questions. Please, if you have a question, just write it on the chat line. I would appreciate if you write your name in it because we don't have access to the names. And for my students at UCSD, if you ask a question, please write your name and a student number. Or if you're online, write it down so I can give you credit for your attendance. I would not know otherwise. Please write your name and a student number. So, quick introduction, very quickly. We published an article in ASHRAE Journal, and this is the cover of the ASHRAE Journal. If you look at the bottom of it, it says Designing for COVID-19. That little thing got most of the attention on that July ASHRAE Journal edition. It was about COVID-19, and it was about our last webinar that we did with Mr. Joel Sanders, who is sitting here, and it was a great success, and it's really, really, really informative article. I wrote that with Stephanie Johnson, she's here with us. But it talks about the 10 lessons learned and how to make makeshift negative pressure patient rooms in response to COVID-19. John Schrank here is going to talk about that. Please make sure if you are planning to do that, follow this article because this article clearly 100% follows OSHPD PIN-4. We have had a great response. In fact, Florida, a hospital in Florida, they wrote and rebuttal, and we're rebuttaling their rebuttal, and they are implementing it. So what is today about? Today is about this. What do we know so far about COVID-19, basically? The question is this respiratory droplets that causes the problem, or are these things airborne transmission? That's the big question. And how do we solve it? It really comes to that. There are opinions on both sides, but there are also facts. I'm going to start with this recent research. It's not conclusive, but John Schrenk is going to talk about this one.
So as you can see, there's an article that was published by the University of Oregon that went into medical facilities and did some testing in the ductwork, and discovered that about 25% of the test samples came up positive for the COVID virus. This indicates that the SARS-CoV-2 RNA is actually in the airstream and is carried back into the return ductwork, therefore actually is fed back into the supply stream.
Okay. So what is ashtray position? So let's talk about this thing. Here is ashtray position, and I'm going to quickly cover OSHPD positions with John and Joel Sanders here. So basically, ASHRAE says transmissions of COVID-19 through the air is sufficiently likely that airborne exposure to the virus should be controlled. So basically, ASHRAE is telling us we don't know what it is, but sufficiently likely that could be. So guess what? Treat it as if it is. That's ASHRAE position verbatim, quote unquote. What does OSHPD says, John? What is OSHPD position?
OSHPD does not have a position as far as whether it's airborne or not. It is up to each individual facility to take their information and process it accordingly. The governor has issued a statement and a directive allowing facilities to make changes on an emergency basis. Those changes can be to the air duct, putting in plastic to separate areas, and it falls under depends as to whether or not there's a OSHPD permit required.
Just to jump in there, at the beginning of all this, we were directed by our director to use and apply PIN-4, which kind of is used for treating TB patients. And that was the basis of the article that Frank quoted me in quite a bit, and some of the engineering practices we put into place is to make somewhat negative pressure environments so that we can control the spread of the virus through the facility.
Very good. So this presentation today covers basically the ASHRAE position on airborne infectious diseases, which has more or less about 9 different recommendations, lack of better words. A copy of this is public information. This was published by ASHRAE in January of 2014, but February of this year with COVID-19, this position paper was reaffirmed. So if you would like a copy of this, please put it in your chat line with your name, and Jenna will be happy to forward it to you. It is also online. You can download this public information. 9 items. I know you cannot read these little tiny things there, so I'm going to enlarge it for you. So these 9 items starts with dilution ventilation, which is number 1, by the way, and goes in terms of not necessarily priority, but in terms of importance to number 9, which is differential pressurization. We will go over each one of them, give you some background, and Tim Jacoby here has personal experience, and he spoke at ASHRAE regarding hybrid natural ventilation hospital. So he's going to also have some input, and then we open it up to questions. So please send us your questions as we go along. So how does OSHPD implement strategies?
Well, basically, we adopt the ASHRAE standards through Table 4A in the building code, or the mechanical code, I should say.
And these numbers, Justin, you want to talk to that?
Sure. Basically, this table is a summary of the 2019 California Mechanical Code for filtration efficiencies, for air change rates in different types of healthcare applications, required pressurizations for different categories of rooms, whether the air needs to be exhausted from the space 100%, temperature and relative humidity requirements. So all of those 9 categories are generally covered in these 3 tables in the code.
So let me make a statement. These are minimum requirements. This is the absolute minimum that anyone can install in a acute hospital or skilled nursing for SNFs. They are and should be increased depending on the need of each hospital.
Very good. So let's start by going one over these infectious disease control strategies. We start with number 1, which is dilution ventilation. So this is ASHRAE strategy number 1. And the table on the right is from California Mechanical Code, which is enforced by OSHPD for any facilities built in state of California.
I like Tim's statement when we were practicing this. What was it, Tim?
Yeah, I'm an ex-Navy nuke, and one of the baseline sayings that I learned many, many years ago is dilution is a solution. And that had to do with radioactive waste in the ocean, or whatever the case may be, which the Navy does a superb job of controlling. But it goes with the ventilation environment too. And, there's 2 fundamentals in my opinion, and this is not just California. I've been throughout the United States now, and having the air exchanges and filtration in many, many cases can help solve this problem for indoor air quality, which is really what we're talking about for the transmission of the SARS virus, inside. And so those, along with in the air exchanges, whether that's all internal or bringing the outside air in, which I'm a huge fan of using natural ventilation, is a huge benefit. But dilution is a solution in many, many cases.
As a matter of fact, we're in a room right now with natural ventilation.
Yes, and cross ventilation as well. So, okay. In terms of dilution, there's more into it than just saying open the window.
Right. So that's generally not an option in a lot of cases in healthcare applications. So what can we do? We have the minimum requirements in the California Mechanical Code. So if we increase above and beyond the required minimums, there are some impacts to that have to be accounted for. Additional outside air is going to put strain on your existing air handling equipment to maintain heating and cooling for the space. So that needs to be considered when we implement the dilution strategy. So there are ways to offset the impact, heat recovery, economizers in your air handling equipment, heat recovery at the main central plant equipment to recover that energy, So we're not increasing utility costs and maintenance.
Okay. So let's go to number 2. We talk about temperature and humidity. And we will start with, what does ASHRAE say? So basically, there are many opinions on humidity and infectious control of the infection diseases. These findings, none of them have been proven one way or the other. There are opinions by many engineers and many hospital staff. We could not find any specific opinion. If you look at 2019 California mechanical codes, those numbers for relative humidity still exist.
We're good.
We're good with that. So ASHRAE standard 170, basically in compliance, and ASHRAE position document that please email us or let us your name. We will forward it to you and other things if you on the chat line with Jenna. And we have received a number of requests, but please go ahead, do it. Maintaining temperature and humidity as applicable to the infectious aerosol of concern is noted there. And our position of ASHRAE is basically non-conclusive, that we don't know how it affects it. So I know I listened to another webinar for other hospitals. They believe in that strongly, but we are dealing only with facts as far as we are concerned. Personal ventilation. I have not had any experience personally, so I'm going to look at our experts. Have you guys, what is your experience? Maybe we can just open it to chat discussion.
Frank, I've never seen it before. It's an interesting concept, but it also raises as many issues as it does perhaps solve issues. So I think this is probably an extreme measure, but it may work.
Patient care may be a challenge.
Yeah, how do you get to the patient? Yes.
It's been a lot. Hi, I'm Sharon. I'm the nurse, and I'm just here to learn.
Yeah.
But I don't know how things have changed in hospitals currently. But I would be concerned oxygen delivery, and then being in a covered tent type of environment. Lots of times ancillary personnel come in and they'll take the tent, remove the tent, or not secure it when they're done doing, let's say, a respiratory treatment, blood work, whatever. And I have seen where the oxygen has not been turned back on. They'll turn it off and not turn back on following their treatment, and the patient will be left in an environment void of O2. That's just my experience.
Okay. Thank you. So let's go on with strategy number 4. That's ASHRAE position. And again, OSHPD has something to say about this.
So again, this is a summary of the 2019 CMC Table 4A, which identifies the spaces. This is a summary of the table, but it identifies the airborne infection isolation rooms. All air is exhausted to the outdoors with no allowance for recirculation within the space to control infection. Similarly, waiting rooms within hospitals are to be exhausted, but they do make an allowance for recirculation if HEPA filtration is applied.
And I think, as indicated by the chart, you can see that code is severely behind what industry should be. Again, these are minimum code requirements.
What you're seeing in practice, though, throughout the United States, and I think Pen 4 reflects it, is that you are creating individual rooms or banks of rooms that are locally exhausted through, the portable HEPA filters units, and quite frankly, they're working very effectively. We've done that in Omaha with a couple of ORs and ambulatory surgery center, and we did it. We created our COVID unit the same way, and it worked exceptionally well. You can do it very, very quickly. It's not expensive. Now you do have to worry about the amount of air maintaining intake or supply, and so you have to do the balancing correctly and set up the exhaust, the HEPA filters, and you have to size them correctly. But it's very effective and simple to do.
Well, and as we noticed from the study from the University of Oregon, you probably want to block off your return air system.
Absolutely. You have to do that. Yeah, absolutely.
Okay, that is basically just not to get off the subject, but we know.
We shouldn't talk about it, Frank.
Okay, exactly. Okay, we don't know of any hospital.
No.
Okay, so this is probably one of my favorite. It's easy compliance with this position paper. It's central system filtration. And I can just tell you, the filter industry within the last 5 years has come a long way, incredibly long. I mean, it's incredible what the filter industry has, including the electronic filtration, which we won't get into it today. But anyhow, we can have filtration systems that they have lower pressure drop and better efficiency. And once again, we go to OSHPD requirements. We start with OSHPD requirements, and we're going to get into some very interesting points. So if you are looking at your emails and bored by now, this is a good time to look up, because we are going to give you some really good rule of thumb checks. First, we start with OSHPD positions.
Again, they're the minimum standards. That's all we can really enforce code-wise. However, we've heard and we've had a little discussion earlier today before the meeting where filtration requirements, doing 100% HEPA filtration throughout an entire building, even if it's not required.
Yeah, and like I mentioned earlier, I just came from Omaha Children's, and we're in the last stages of building a 430,000 square foot addition for the Children's Hospital, and we made a decision 3.5 years ago to HEPA filter the entire building, and that added, on a $400 million project, added $158,000 to the cost of the project, which is simply not a material cost, and the safety factor that adds to the facility is incredible. I guarantee you the physicians and staff loved it.
Well, it's not just safety, it's flexibility too.
It gives you a lot, you bring up a great thing, Joel. One of the things is we don't know what's coming next.
Right.
What pandemic or we live in very dynamic times, and that's not going to change. And so flexibility for hospital design in the future is going to be key, not just for the systems, but for the operations. And so, because we don't know, so you've got to be flexible. And I was on a webinar not too long ago on, well, what would you do different? I'm not real sure what I would do different, other than your design has got to be flexible enough to cover many different cases. Mm-hmm. So do you build a waiting room so that it's larger, or that you only, can only hold X number of people to, well, that's great, except if you have a very, very busy ED and you don't have the pandemic and you have to have, so again, you don't know what's coming next, so design for flexibility.
Or, for instance, I had a facility that they took half their waiting room and turned that into a COVID bay.
Yep.
But you have to have that flexibility design to do that.
Yep. Agreed.
Okay, now let's talk about central system filtration, which we touched on it. Tim, you decided to put HEPA filters in the entire hospital, which made the hospital safer. There are other hospitals, they may have some pushback saying, hey, that increased my utility costs or maintenance and possible equipment retrofit. Do you feel that in a long run, knowing that infection control and now the legal system, the cost of doing that, in a long run, you think you save the hospital money? What's your thought?
You know, there's the 4 bullets on the top of the slide are totally valid. You can't argue though that they're valid. I'm not sure about the increased maintenance. That may or may not be true, but the rest of it is, now if it's a new facility, it's not an equipment retrofit. Retrofitting to put the HEPA filters in could be problematic, depending upon the space that you have available to do it. That could be problematic, but for a new build, it's pretty simple. One nosocomial infection, that's that a patient gets through an airborne issue outweighs the cost of all of this. And nowadays, with the efficiency of air handling systems, with chillers and boilers and stuff like that, it's really not that much more of a utility cost. When you're using a VFD and everything else, it just is not the same as it was 30 years ago. So yeah, it's an increase. Do I consider it material? I don't.
Excellent. Yeah. Okay, I'm going to move on. Thank you. I will not go over this slide too much in detail because it's self-explanatory, and we will provide you with a copy of the presentation. But it shows you, for example, MERV 17, which is a HEPA filter, is 99.97% efficient. And if you look at most of the documentation, it talks about MERV 13 and shows the efficiency. So, and it's a very, very informative slide. You see it. But I will go over this slide, which comes from my class at UCSD, and I covered this slide. If you look at coronavirus size of the particles, they are roughly about 0.11 microns. And if you compare it to in a flu, which is 0.1, or SARS virus, they're almost identical sizes. So folks talk about using HEPA filters. HEPA filters are 99.97% efficient. And you may be confused. You say, hey, they're 99.97% efficient for 0.3 microns. So coronavirus could go through these. Well, that's not true, because there are phenomena which was researched by NASA study, and the effect is substantially greater than that. And Tim, you were a nuke officer, so you would know more about HEPA than anybody.
Yeah, the NASA did this in a detailed study, and basically what it uses, or what the effect is, called Brownian motion, and it's just basically a saying rebound. It hits something and it rebounds, and in due time it will get filtered, and that's the long and short of it.
Okay, so bottom line, use HEPA filters. It will significantly reduces contamination, and again, we don't know if it's these are aerosols or not, but that's what we're treating them. Number 6 on our top 10 list, or top 9 list, is upper room UVGI. There are 2 types of ultraviolet protection in the system, and one of them is called upper UVGI. And John, UVGI stands for what?
Ultraviolet germicidal eradication.
And those, you can see it in the picture on the top left. It's usually installed 7 foot and above, and you're not supposed to look into it, but since it's 7 foot above, it aims the other direction, so it's as safe could be. ASHRAE position paper covers it. I personally don't know how good they are because how many of them you could wear, but that's lack of my knowledge.
I've never seen them in a hospital installation, but I think all of this COVID-19 is going to change things forever. So I anticipate we're going to start seeing devices such as this.
I know of one hospital that's planning on putting them in patient rooms.
Oh, every patient room?
Yeah.
That is huge.
Mm-hmm.
That's a huge cost, and that is huge. Okay, so we are in a new world we live in. I think
They've been using items like that in ORs and stuff like that, the portable units to go in and terminally clean at the end of the day. It's very effective. You know, they've been using them for years.
and you found them to be effective.
They're extremely effective inside the ORs and stuff. Or it kills everything.
Yeah, it basically changes the DNA of the virus. Basically, that's what it does, so they cannot continue. Okay, I do not know as much about the upper. I've used many of them inside air handling unit, which is the next one we're going to come about. And this is also for my class. I just want to throw this out there for those of you who are considering that. If you look at this graph, basically, there are three types of UV lights, UVA, B, C, and that's basically their wavelength. And the one that is really effective, it's around, if you look at that graph, if you can see, it's about 265 nanometer, the wavelength is most effective. And that's closest to UVC. UVA and UVB does absolutely, well, it does something, but very low, almost nothing. So we want to use UVC for the engineers on the line that they're specifying that. So that's a little tidbit for engineers. Also, we go to number 7. And number 7, I have used many of these. Our company designs hospitals. And Tim, for your hospital, for children's, we use these.
Yeah, I can't imagine not putting them in now.
Yeah, exactly. So it's not required by law or by code, but there's something said, it's called the standard of care.
I think a lot of this is going to be driven by infection control departments within each hospital.
Yeah, and
and going back to what Jim was saying, a nosocomial is a hospital-acquired infection. And most of the time, the hospital is liable for the cost. So if we can mitigate that by preventing a lot of this, it's cheap insurance. We can go from there.
totally agree. And as a consulting engineers, for those consulting engineers online, standard of care is not the code, it's what other typical engineers do under circumstances. And today, these are the circumstances. So these are the type that you've seen. We talk about upper level room air, but there's also through the live stream and HVAC coil surface. Personally, I have been involved with many of them. The most effective one for us has been the one HVAC coil surface because it's wet, bacteria grows, and also infectious control. The swabs were on the coil at the University of Oregon. So that's the place that air slows down and touches the water. We have had extreme success with putting UV light on coil surfaces. The other two I cannot speak to personally, but I just heard from the experts here that they have been successful. But that's part of the actual position paper. Now, this is a very telling slide. It was provided to us by one of the manufacturers, and it shows you the effect of UV lighting on different bacteria. So if you look at the very, very left of this screen, it talks about Aspergillus and basically mold. UV light has very little effect, if nothing, on mold. But if you look at the very right, when you look at flu and viruses and smallpox, UV light is most effective. So that's a really good lessons learned for me. I tried to, in the past, unsuccessfully deal with mold and doesn't do anything. So, well, we're coming to an end. Close. This is number 8, and in-room flow regimes. That is huge. Basically for operating rooms, huge. Air change per hour. I know some of my very esteemed ASHRAE colleagues have questions regarding the validity of air change per hour. So I am basically looking at the experts here. So operating rooms, laminar flow over the table protects the patients. Basically, that's what it says. And this ASHRAE position paper has to do with the airflow pattern and how many air change per hour. This is the computational fluid dynamics configuration of an operating room with stereo flow, with laminar flow from the top to the bottom. The idea is we want to bring air at the low velocity, somewhere between 50 to 100 foot per minute. We don't want to bring it higher velocity because it impinges the dust into the patient's open wound, or maybe the wound gets dried if it's too high a velocity. We want to wash the surgeon's body with air and exhaust it at the lower level. And this is it's there to stay unless you guys think otherwise. One solution is displacement ventilation. Very few hospitals that use this. This is used traditionally in England with old facilities, churches and such with high ceiling. That's where we bring larger amount of air change per hour at the warmer volume on the bottom, and then wash the floor and exhaust it from the top. This is one item mentioned. Currently, it's not used at hospitals, but we need to think about these things because guess what? There were present. This brings basically pretty much outside air into the room at the high level filter there. And using natural ventilation for patient rooms are unheard of in this country. Nobody ever does it. But there are studies done that natural ventilation, an openable window, an open balcony for every patient rooms that's protected, so patients cannot be hurt if they fall. They have been shown that it actually improves the patient health and the speed of recovery. Tim, you spoke on that at ASHRAE. Can you give us a quick overview?
Yeah, there's been a lot of study, and matter of fact, many years ago in the United States, it was fairly standard. And then the code changed, and it's no longer allowed in most cases. But you get outside of the United States, and natural ventilation is pretty common in hospitals. And I am a huge believer in it. Maybe not, that's a general statement because it's not appropriate in every application, but in many applications, it absolutely is appropriate in my opinion. And it creates a very good healing environment.
Okay, codes are being changed as we speak. We think we'll see. Last item on this ASHRAE strategy is differential pressurization. Basically, go back to OSHPD. Again, the table speaks for itself.
Yeah, again, this is a summary of the 2019 CMC Table 4A, where they require special pressurizations for different kinds of spaces, negative pressurization for airborne infection isolation rooms, positive pressurization for operating rooms to prevent contamination, and again, negative pressure for waiting rooms. Other areas, they don't have requirements, but that may be changing.
So I am going to move on something based upon this. Basically, this has to do with measuring the CFMs and measuring the pressure and making sure that the room is positive or negative, or verifying the CFM and test and balance. And ladies and gentlemen, test and balance at the end of the job, it always takes a lot of time, always a source of delay. Guess what? We had an opportunity with John Schrank to present at ASHRAE and at ASHI, I believe we spoke. And recently we met in OSHPD LA, and I told you we have some solutions, and this is one of them. It's automated reporting through building automation, and we met with all the engineers, mechanical engineers at OSHPD in LA, and I'm going to turn it over to John to talk about that, because that's important.
So Frank and I have been working on this concept for 1.5 years or more, probably close to 2 years. So the whole thing is having automated devices within the duct that read the airflow, rather than having to go up with a hood and read it. So we're going backwards. CMS, the feds require all critical care areas to be verified every year. So facilities are paying upwards of $175,000 to $100,000 every year for just the critical care areas to balance. Imagine if you could take a computer and say, I want this every day. I want to look at a trend. And all that information is constantly monitored. So it's something that Frank and I presented to the mechanical engineers within OSHPD for the concept, and got a preliminary approval that this would meet code. If a facility were to do that, they would not need an alternate method of compliance.
Frank, when do you think an ROI, because in a lot of cases it comes down, you're adding parts to the control system, and so the control system is probably more robust, which means a little bit more expensive. I'm a huge fan of pretty robust control systems, but it comes, in many cases, it comes down to dollars. When do you think the ROI, or could you work out a basic ROI on something like that?
On a new building, you're going to save it immediately.
Could you work numbers? Is it possible to work numbers to see what
These
that would
guys
be?
do have.
Yeah.
Yes.
We've been working on it for 2 years. We actually did an imaginary hospital, and like Joel mentioned, our imaginary hospital at payback of less than 1 year, which is incredible. But that's an imaginary, a lot of assumptions, it could go extreme one way or the other.
But if you're building a new facility, what's your time? We're talking about cutting out time on your construction site.
No, I'm a huge fan of this. I mean, and you can do it, you can do continuously balancing too. And so you don't have to, it solves a lot of problems.
It does. So it's something that you're interested, contact Frank. We can always set up a meeting specific to your organization or in a general setting.
Yes, we actually did present that at one of the healthcare facilities. We are coming to an end of our presentation, and we're going to quickly open it up to questions that you have been asking. Basically, this summarizes what we talked about. And ladies and gentlemen, we are done with our presentation. Thank you. Thank you, panel. And we can go to our Q&A session.
Good morning. My name is Jenna. I will be reading the questions, and then the panel will be answering. The first question we have is, what about putting UV light in the return duct? Could this be used in place of higher MERV filters?
Refer to the panel.
OSHPD goes by code, so we're going to be looking towards ASHRAE to what are their recommendations. As Frank stated, the normal and the best industry standard is to put the UV at the coil. Why not protect it at that location? If you're going to install it, you're taking the same air regardless, but you're putting it at a source that has more susceptibility to having the virus, the molds, etc.
Yeah, I agree, and it's also, if you put it at the coil, you're also getting not just the return air, but the outside air and everything. And so it's probably a little bit more efficient, probably a little bit better coverage for the whole system.
So I don't think we typically use both in series as a means of protection. Typically, I would not see UV as a substitute for filtration. Generally, the intent is to reduce the overall amount of airborne infection in the airstream. So a combination of both UV and filtration is recommended.
And you're still looking at removing dust and larger particulates, so you need some filtering no matter what. Your pre-filters.
I think you guys all hit the nail on the head. Basically, I don't believe I am involved very much with ASHRAE. I don't think we have done a study on returner duct with UV. But I just tell you this, at the coil level, the reason we have had so much success because we reduced the velocity of the air to about 400 foot per minute or so. At the returner duct, it depends upon the size of the duct, you're looking at 1,500 foot per minute air. You got to put a ton of UV lights, and you better be quick with UV. Mm-hmm. About 1,500 foot per minute. So, okay, that was a good question. Jenna, we're looking at you again.
Sticking on UV, next question is UV for number 6 same as UVGI? I think based on the presentation.
Frank, I think that you got muted. Your speakerphone's muted. Jenna, can you hear me?
Justin, I can hear you.
Yeah, I'm not here. I think somehow Frank's speakerphone got muted, and I can't seem to unmute it. If you go to his Teams meeting, there should be an unmute button.
Can you hear us now?
Yep.
All right, ladies and gentlemen, we are back. That was only a test. So let's go back on item 6, which we are on. Upper room UVGI. I believe we're talking about that one. So, Jenna, can you read the question again?
Is UV for number 6 same as UVGI?
Yes, it is.
Yeah, so it's just in terms of the location of the application. So upper room UVGI is UV located within the space as opposed to in the air handling equipment or within the duct.
I believe you touched on this, but if there's anything else you would like to add, the next question is, would it be a good idea to combine 2 of the UV applications, such as upper level room air for the individual rooms, while also having the UV on the coils?
I think John is nodding his head. John, what's your opinion?
I think it's a choice. You have redundancy. You have a better chance of filtering and killing the viruses, but it goes back to a cost factor to the owner.
It also, we actually do, a lot of hospitals actually do that right now. A lot of healthcare air handling systems already have the UV built into the air handling units, and then in the evening when the OR they're done, for example, they have an ultraviolet machine that goes in that they sit in there and sweeps the room with the ultraviolet light. And that's really not for airborne contamination, that's for surface contamination. And so it kind of depends on what you're trying to do.
Yeah, and you know what, we live in a complex world, and there are more than one factor. I remember clearly when the energy became expensive, we at ASHRAE talked about nothing but energy, like turn this off, turn that. I mean, it's crazy. We went the other extreme. Now, these things, they all use energy, and there is some reasonableness to these things. Next year is going to be a new thing. So we have to be reasonable. And I think when there were questions about bad guys putting contaminants outside the building and you come to the building, we went crazy with that. No ductwork below 10 feet, but I think that was Amtrak's as one of the things. So I think there is a reasonableness, and that reasonableness is different for different applications. Can you do it? Yes. Is it add energy cost? Yes. Does it add initial cost? Yes. Is that initial cost better to purchase a MRI machine or put more UV lights? Those are rhetorical questions I don't know about.
So in terms of the upper room UV GI, putting that in every room in the hospital may not be practical, but locating those where concentrations of infection may be highest, maybe an alternative in a compromised air handler UV.
Okay, Jenna, are you ready for the next question?
The next question, is ionization something that could be used in this application, or are filters and UV-GI better options overall?
Ionization, is it better than the UV?
My understanding of ionization is attraction through magnetizing particles, so collection of dust. Is that going to have a significant effect on a small micron virus? I don't know.
And that was one of the items that was discussed and mentioned. Unfortunately, we don't have enough data on ionization to make a conclusive factual statement. However, in the same token, there are several manufacturers that they have done very, very, very valuable testing and data for ionization, and they swore to it. And we talked to another colleagues of us, won't mention the name of the facility. They have successfully implemented that in their hospital, and they strongly believe in it. So thank you very much.
Next question. You keep saying you look to ASHRAE for guidance, but in the midst of a pandemic, wouldn't OSHPD be making the recommendation since it's on the front line dealing with the virus?
Absolutely not. OSHPD is a building department. We don't make regulation, so we enforce the regulations. So this is driven by the client's needs.
Kind of a lot of what Frank and I were doing when this first started is really just trying to apply some logic and apply the knowledge that we have to help facilities not make bad decisions and compromise the facility more than they needed to make some of these environments safe for the patients.
Yeah, we were on the phone on a Sunday back and forth with OSHPD home office with Hossein, specifically Sacramento, yeah. And you will be surprised how many hospitals try to do the right thing, but we needed to
They needed a little direction and a little application of like the policy intent notice there. or code application notice, and all we can do is recommend. You know, there's no specific code that deals with a pandemic, so we can't enforce anything. But we're trying to enforce or trying to be a resource so that we can apply some engineering principles to make it work right.
And John, to his credit, Hussein at Sacramento on a Sunday got on the phone with Joel Sanders, and between the two of them, they were just, it was very, very helpful for the hospital.
Yeah, I think one of the important things is to have open, and transparent conversation. And, this is a team. You have to have teamwork on this, and help each other solve the problem. Seriously, it's we have to fight this together. We're all resources.
It's interesting because I've told somebody, OSHPD, we were conceived because of earthquakes. So we were initially responding to earthquakes. Well, our role has now become, we respond to earthquakes, fires, floods, and pandemics now. So, we're all learning together.
So, ladies and gentlemen, I am going to, we have too many questions to get to. I'm sorry, I told you I would get back to all of your questions. There are too many. And we will get back individually with you guys or anybody who has questions, or please call us. I want to be respectful of everybody's time, and I'm going to go to our panel of experts for closing remarks. And I think the biggest learning experience for me is working together collaboratively with OSHPD. I always have to bring that to you, John, when we had that seminar and someone got up and said, well, we are scared of you. And he said, what? You work with the biggest healthcare group here. You should be working with me.
They're not using us as a resource. We are the owner's team member, and we are a resource in which they should use us. So let me make a couple of real quick comments. One of the concerns that's coming up through all of this, where we are converting floors to negative, EDs to negative, is, are we labeling the exhaust on the roof as we do with negative pressure isolation where we have TB patients? Must be labeled. Something for the owners to concern. The ducting and labels should be up there to prevent their staff, anyone working on a roof, from that air.
Good. I'm going to go to our other speakers. Tim, any closing remarks? We got 1 minute.
Yeah, I appreciate the opportunity. I've been back to California for 3 days now, and this has been a wonderful learning experience for me, and I'm thrilled to be back, and thank you for the opportunity.
Oh, we'd love to have you back. Mr. Sanders.
Well, Frank, I'm going to look at your title. Back to normal? Stay tuned.
Well, ladies and gentlemen, thank you so much for joining us in this webinar. We are very grateful for this opportunity. And don't forget to do the survey, please. There is a survey there. We really appreciate to get your feedback. Have a great day, and we will see you at our next webinar.